Hello, this is Cam from Pulse Cardiac Health, and in this video we are going to be talking all about angioplasties. So coronary angioplasties, so for the coronary arteries. Now I will start by saying there's a couple of other terms that you may hear an angioplasty called. One is, it's very common, is called a PCI. PCI stands for percutaneous coronary intervention. Percutaneous just means it's through your skin, so it's through your wrist or through your leg. Coronary is the artery that we're fixing. Coronary arteries, the arteries that give your heart muscle its fuel. And an intervention is intervening. We're doing something about it. We're opening something up. Another term you might hear is a PTCA. Percutaneous, again through your skin. Transluminal, we're going through a blood vessel. Coronary angioplasty. So basically the same thing. Some people just say, I got a stent. So why would you do an angioplasty? Well, first you have to have had an angiogram. There is a video on angiograms, and if you haven't watched it, I would watch it first. So an angiogram tells you if you have a blockage, how bad, where it is, and all that kind of stuff. So if after your angiogram, the cardiologists or the physicians think that doing an angioplasty and opening up that blockage with a balloon and a stent is the best option, now you're into the angioplasty. So there's sort of different urgencies in doing an angioplasty. If you are somebody who has come into an emergency department and actually having a heart attack, you can see your symptoms and see your heart tracings on your ECG suggest you're having a heart attack. We zip you off to the cath lab and do an angiogram, find a blockage, open it up right away. That's an emergency angioplasty. Sometimes you have symptoms and you've told your doctor that when you walk up a hill you get chest pain, and they go and do a stress test and it suggests you might have a blockage, and then you come in and you get an angiogram done and we find a blockage, and then you come back, you get on all the right medicine, and you come back later and we open up with a stent. So there's a few different ways that you can get to this angioplasty. I'm going to talk about basically what an angioplasty is and the ways that they do the stents to open things up. Okay, so very much like an angiogram. We can go through your wrist or through your groin, clean, prep. When you're lying on the cath lab table, the doctor is going to freeze the skin, they introduce the tubes, and you get this tube up to your heart. Okay, so it goes against blood flow through either your artery in your wrist or your artery in your groin, comes all the way up to the opening to that artery that has the blockage in it. So once that catheter is sitting there, the nurses in the cath lab are going to give you some pretty high powered blood thinning medications. And the reason we do that is because we don't want to get a clot on these wires that are going to be down in through these coronary arteries. So you're on some pretty high powered blood thinners. The risks of bleeding goes up, but we manage those risks as much as we can. Okay, so once this tube is in the right spot, the doctor is going to pass a wire, a really thin wire, all the way through that tube. And then it's going to actually go all the way down past the blockage in the artery. So the tube itself, the catheter, sits at the opening to the artery, and the wire goes all the way down and past the blockages. Okay, and that acts as a rail, and that rail is what we pass stents and balloons over top. So sometimes they will choose to open that narrowing up a little bit with a balloon first because it's too tight to get a stent in. Sometimes they can just go right in with a stent, and a stent is loaded over a balloon anyways. So regardless of which way they do it, they're going to pass this balloon or balloon and stent along this rail, this wire, and it goes all the way down to where that blockage is. On the stent, there's actually two little markers that you can see under the X-ray camera. So we will inject contrast to show us where that blockage is, and then look at those two markers on the stent or balloon until they get in the perfect spot. Once they're in the right spot, we will inflate the balloon, and we inflate the balloon with a special device, and it has contrast in it. So it opens up the balloon, and if it's a stent, it opens up the balloon and the stent is around it. It deploys the stent. So it opens it up, pushes the stent open, and then when we're done, usually it's about 10 to 20 seconds, we deflate the balloon, pull the balloon out, and the stent is left in place. If it was just a balloon, we will obviously go back in later with a stent, deploy the stent with a balloon, take the balloon down and pull it out. And the stent stays there. The stent always will stay there. It's not big enough that it will set off the metal detectors at the airport. It's a very fine chicken wire almost. Stainless steel, so it won't rust inside you. And it stays there for life. It kind of pushes the plaque back. It doesn't get rid of any plaque, it just pushes it back and opens up that vessel. So it almost stretches the vessel. Sometimes people get discomfort when we inflate the balloon, and that's because we're blocking blood flow down the artery. So it's like you're having angina or even a heart attack in a way, but it's only for a few seconds, so it doesn't cause any damage. But it's the same sensation. Your body doesn't know what's blocking blood flow, but in this case it's just a balloon that we inflated. Sometimes you can have some pain after, just because that ache of the stretch in that artery can be a little bit uncomfortable for a little while. Now, we're doing an intervention. There's risks in these procedures. You know, there's bad risks, heart attacks, strokes, dying. Heart attacks might be we block off another artery while we're trying to save this one. All of these risks and benefits get weighed by the physician before. And sometimes if you're actually having a heart attack, the risks of not doing this procedure are worse than the risks of doing it. So they look at all the scenarios and decide, okay, this is anatomy where we would like to do an angioplasty and open things up and make you aware of what they're going to be doing and carry on. So they really minimize all the risks that they can. So now you've had this procedure and they've opened things up and put in a stent. You will need to be on special medicine after you get this stent, because this stent is a piece of metal. It's foreign. It's not what our body expects to find in its coronary arteries. So our body would like to attack that stent, and the way it does is it has these little blood cells called platelets, and they stick to the stent and they can start the formation of a blood clot, and that blood clot can block blood flow down the artery, and now you're having a heart attack. So you need to be on antiplatelet medications, usually for a year after that procedure. The most common stents we use are coated in a special drug that slows our rate of covering up the stent with cells. So it takes about a year for our bodies to grow a layer of cells over top of the metal stent so that our body doesn't see it. Once we have this layer of cells over top of the stent, we generally don't need to be on that special medication to keep us from getting a clot in that stent. You're going to be on aspirin forever, and you'll probably be on some cholesterol medication because we now know our bodies like to make plaque. So if you've created a blockage once, you can do it again. So to minimize your risk, you're going to be on cholesterol medication and aspirin forever. There are special stents, or not special stents. The older stents didn't have the drug coating on them. And in that case, we would only have to be on these blood thinning medications for about a month because our body's covered over the stent quicker. There was a bit more risk with those because we would grow too many cells too quickly, and it can narrow that artery again fairly quickly. So that's why they go with the drug-coated ones. Our bodies grow this layer of cells quite slowly over the course of a year, and we're less likely to re-block off that stent. So that's a basic angioplasty. There are also some other fancier things we can do. Sometimes if a blockage is really hard, calcified, old, we actually can use a drill. It's called a rotablator, and it'll pulverize that calcium into small little wee micro bits, and then we can get in there and open it up with a stent. And there are some fancy balloons and different things that we can use to try and fix up arteries. The doctors that do this procedure are quite amazing with what they're able to do. And you know, if there's side branches coming off, they do all kinds of fancy techniques. But basically what we're doing, an angiogram, getting the tube in, running the wire down past the blockage, using it as a rail, sliding the stent over top, opening up the balloon, deploying the stent, deflating the balloon, pulling it out, and the stent stays in place. So I hope that was an informative talk about angioplasty, and we will talk again another time. Thank you.